Hi guys, this is Dr. Patil here and this is a video module dedicated to tuberculosis. If you're someone who had been following up with the PrepLadder NETSS platform from the edition 1, you would have noticed that edition 1, the ID modules were quite compact. They were primarily dedicated to those infections which I believe that are kind of taken for granted by medicine PGs. For example, as a medicine PG or for that matter even as a pediatrics PG, we really don't try to learn too much about staph, strepto, pseudomonas, klebsiella. These are like taken for granted infections. So we know what antibiotics work well for them. We know what is the updated guidelines with respect to antibiotic of choice against these infections, and we restrict ourselves to that. But if you look at previous NEET SS papers, there were a lot of questions which were about basics of those infections. So we try to primarily draw your attention to the basics of those infections in the version 1. Okay, so it was generally believed that HIV, tuberculosis, dengue, malaria, for all these infections, medicine and pediatrics PGs are pro when it comes to its management. So we didn't try to go deeper into these infections in the edition 1. But now that exam has metamorphosed into this all 150 marks, all general medicine based question pattern paper, right? Now it definitely calls for a little attention to these infections also. Even now, I'm not debating about the medicine PG's knowledge of management of tuberculosis, HIV, and all. The whole theme of these ID modules is getting back to basics, because as we start ascending up in our residency ladder and we become a full-fledged physician, the basics that we learned about these infections in undergraduate days, we have a tendency to, kind of our knowledge of those basics starts disintegrating. So now we become like a sophisticated physician who knows everything about the updated guidelines. So we will start quoting numbers and studies to say that this works, this doesn't work, but basics become phased out. So today we are going to get back to the basics of tuberculosis, right? So all these ID modules, the focus is on getting back to basics. So let us get back to the basics of tuberculosis. So when we talk about tuberculosis, we know that it is caused by mycobacteria. Examiner from the microbiology might ask to which order these mycobacteria belong to, right? So the order that mycobacteria belong to is actinomycetales. Actinomycetales is the order. The genus is Mycobacteria. Now MTB is not the only mycobacteria that cause human infections. So the mycobacteria that cause infections in human are broadly grouped into 3 groups. Okay, so the first group is our MTB complex, which causes human tuberculosis, MTB complex. The second group is non-tubercular mycobacteria. They cause human infections but not this conventional tuberculosis. And the third component of this grouping is a standalone organism, that is our Mycobacterium leprae. Right? It's a sole organism, not a group. Mycobacterium leprae. Now, from the exam perspective, we should definitely know what organisms come under MTB complex and what organism come under non-tubercular mycobacteria. So in the PGI, there used to be this common template of MCQs where they will give 3 NTMs and 1 MTB complex, and then they ask you which of the following is not a NTM organism, right? So this knowledge is very, very essential for us. So what are the organisms that come under MTB? The first one is obviously MTB itself. Okay. Second most common cause for human tuberculosis is M. bovis, right? Mycobacterium bovis, M. bovis. Okay. Apart from that, certain geographically restricted infections like M. africanum, then we have this M. caprae, then we have this M. microti, right? Then we also have this M. canoti. These are the important MTB complex organisms, right? Before we go to NTM, just few words about M. bovis. So today the whole focus of discussion will be on Mycobacterium tuberculosis, which in humans primarily enters through the respiratory route, causes respiratory infections and can also cause extrapulmonary tuberculosis. But when we talk about M. bovis, it primarily causes intestinal tuberculosis. So for MTB, the usual source of infection is an active open pulmonary TB case. So humans are the reservoirs for MTB. The reservoirs for M. bovis is cattle. Cattle are the reservoirs for M. bovis, right? So because cattle are the reservoirs, the entry from cattle to humans is through contaminated or infected milk. So when someone who is probably having lesser of a cell-mediated immunity, who gets exposed to this cattle milk, which is contaminated or infected, right, such patients will go on to develop intestinal tuberculosis, right? They will develop intestinal TB. Is M. bovis infective? Like the infected humans, are they infective to others? Definitely not, because an infective case, mostly when it comes to human transmission, occurs through the droplet spread, right? Because it is an extrapulmonary TB. Extrapulmonary TB usually doesn't cause human to human spread. So M. bovis having caused the intestinal tuberculosis doesn't cause human to human spread. Okay, clear? Okay. Now, what are the organisms that should be listed under our non-tubercular mycobacteria? Okay, the first thing that should come to our mind is this opportunistic infection called Mycobacterium avium intracellular complex, MAC, right? So we will be discussing more about it. Now, apart from that, there is one organism called M. marinum, which is known to cause fish tank granuloma. This is one more important MCQ. Fish tank granuloma is caused by which organism, right? It is M. marinum. Okay. Now, apart from these, we also have this M. fortutum and M. chelonae. These are known to cause skin infections following trauma. Skin infections following traumatic inoculation causing skin infections. So more of that we will discuss at the end of this session. For now, for time being, just remember which organisms are listed under MTB complex and which organisms are listed under non-tubercular mycobacteria, because both of these are MCQ areas. Okay, so having understood this, now let us get back to the main bacteria for today, that is our MTB. What are the important points one need to know about MTB? We all know that it is a bacilli, right? It is a bacilli which is strongly aerobic. It's a classical example of an aerobic bacteria. Now, why am I talking about aerobic nature of this? Because we know we clinically correlate these bacteria or this MTB is usually affecting upper lobes more predominantly than other lobes. The reason for that is that upper lobes are well aerated, well oxygenated, and this environment is what helps this bacteria to thrive because it's an aerobic bacilli. Now, is tubercle bacilli gram positive or gram negative? They are usually weakly gram positive. They are usually weakly gram positive. Okay, and definitely we all are aware about the acid fast nature of these, right? So we call them as acid fast bacilli, AFB. MCQ wise, they might ask you what is the component of the bacterial cell wall that confers the acid fast nature to this, right? So the acid fast nature is because of presence of mycolic acid. Mycolic acid is nothing but a long chain fatty acid. It's a long chain fatty acid. So mycolic acid is the one that confers the acid fastness to these bacilli, right? They might ask you what are the stains used for demonstration of acid fast. The commonly used stains are Judin stain and or Kinneon stain. These are the two stains which are commonly used for demonstration of acid fast nature of this bacteria, right? Clear? So these are the key points that we need to know about Mycobacterium tuberculosis. Now, with this understanding, let us talk about the pathogenesis. Yeah, before we move on to pathogenesis, there is one more important MCQ area from which often MCQs are asked. Apart from MTB, what other organisms are acid fast, which can be a confounding factor or which can be confusing factors when we are discussing about MTB infection, particularly like nocardia. So you have a respiratory illness. Nocardia also can cause cavitary lesions. Nocardia can also be acid fast positive, acid fast bacilli, right? So Isospora, Scriptosporidium, Legionella amygdalae, Mycobacteria, like we were just talking about it, Nocardia and Rhodococcus. These are the organisms which can be acid fast, right? Okay. Now, coming to this pathogenesis, few points to address. First is what is the source of infection. So today we are talking about MTB. So humans are the source of infection. So humans are the reservoirs, and the source of infection for a non-infected individual has to be a pulmonary tuberculosis, open case of pulmonary tuberculosis, a sputum positive case of pulmonary tuberculosis, right? So the source is usually open or a sputum positive pulmonary TB case. Extrapulmonary TB generally do not cause infection, human to human spread, right? So it has to be a pulmonary spread. Now, how a potentially non-infected person acquires the infection? The mode of transmission is usually through droplet spread, right? Through droplet spread. It is usually through droplet spread. Most of these droplets are in the size of 5 to 10 microns, right? So now we all know that the droplets which are less than 2.5 microns, any particle which is less than 2.5 microns can only make its way to the alveolar spaces, right? When we talk about tuberculosis, we have to remember that tuberculosis causes parenchymal infection. This is not an infection of the airway. Yeah, airway can get affected. I do agree that there is something called as endobronchial tuberculosis, but that's not where the primary infection occurs. So primary infection occurs in the lung parenchyma, what we call as Gons focus. From there, yes, there can be dissemination, secondary inoculation, other sites, and infection can occur. But primarily, it is a infection of the lung parenchyma, right? So that means these bacilli these droplets have to reach the lower airway. Can these particles reach? Obviously no, right? So more than 90% of these droplets are filtered out by the ciliary conveyor belt. So cilia clear more than 90% of these droplets. So less than 10% of the droplets will make their way into lower airway, right? Okay, so once they are inoculated into the lower airway, they can cause the parenchymal infection, right? Okay, so in fact, during this COVID pandemic, we were talking about like if all Indians stringently continue to wear masks, which are standard, like your N95 2.5 micron filterable masks, probably we will get rid of the tuberculosis in near future. I know certainly that it will never be a possibility because we can never be serious about the masks as such. We had plenty of COVIDiots roaming around during COVID, but just I'm talking about there was a debate that we may be able to eradicate tuberculosis if everyone wears masks sincerely, right? Okay, now coming to the pathogenesis of this, few points to address before we discuss pathogenesis in detail. Okay, I definitely want your attention on this topic because if you learn pathogenesis well, then you will be able to correlate a lot of things when we about tuberculosis, like the diagnostic procedures or diagnostic modalities, treatment modalities, and certain conditions where the TB reactivation is known to occur, why it occurs. All that you will be able to correlate, and that will definitely help you to remember for life. Okay, so I definitely want your attention on the discussion of pathogenesis. But before that, few points to address. Point number one, when it comes to tuberculosis, once we have got the tubercle bacilli in our systems, in our respiratory tissues, right, body does not produce humoral immunity. If it is producing, it is quite negligible. So far we have not listed any particularly important antibodies. So we don't have any antibody based tests. We don't have cards to detect antibodies against tuberculosis, right? So primary defense against tuberculosis is cell mediated immunity. That is the first point. And in humans, the tubercle bacilli have to survive inside the cell. So they are kind of intracellular organisms. For their replication and survival, they need to be inside the cell, right? So this is the second point I want you to remember. These are intracellular pathogens. Okay, so now let us talk about someone who has inhaled these droplets containing tubercle bacilli. So some of those bacilli have made their way into the lower airways. Now, what is the primary response from the host when the bacilli land up in the pulmonary parenchyma? The first cell that would try to handle these bacilli is macrophage, right? Macrophage is the first cell that will try to handle these bacilli. How will it handle? It will try to phagocytose these bacilli and then try to kill it. That's the expected phenomenon. So these bacilli actually want to be phagocytosed because these are intracellular organisms. They want to make an entry into these macrophages. Okay, so clear? So how the entry occurs? These bacilli are recognized by the macrophages because of the presence of a particular substance on its cell wall. So all these macrophages mainly recognize the pathogens because of a presence of a special receptor called as mannose receptor, right? So macrophages have this mannose receptors. So if you remember, as I've already told you, the mycobacterial cell wall is primarily made of lipid layers, right? So it has mycolic acid that confers the acid fastness to the bacteria. Now these lipid molecules can also be paired with various carbohydrates, so that gives it certain virulence factors, and that also facilitates various other activities of the mycobacterial cell, right? So one of that is what we call as mannose capped glycolipid. So on this mycobacterial cell, some of these lipid molecules are paired with mannose. We call them as mannose capped glycolipids. These mannose capped glycolipids are recognized by this mannose receptors. So there is a fusion of these mycobacteria, binding of these mycobacterial bacilli with the macrophages through this mannose receptor mannose capped glycolipid pairing. Once they attach, right, the mycobacteria is engulfed into the or phagocytosed into macrophage, right? So once the bacilli get attached, this is all phagocytosed into the macrophages. Now once it is phagocytosed, unfortunately these macrophages may not be efficient enough in destroying these mycobacteria, and it can start replicating inside the macrophages, kill these macrophages, recruit more macrophages and infect them, and thus the infection propagates. So probably for the human body, the best defense against tuberculosis would be not to allow macrophages to phagocytose these bacilli. Do we have something like that? Yes, we have a protein called as NRAMP1, right? We call it as NRAMP1. What this NRAMP1 stands for? NRAMP1 stands for naturally resistance associated macrophage protein 1. It's called as NRAMP1. Okay, so this is usually coating the cell surface of the macrophages. So this acts as a defense against phagocytosis of the MTB bacilli. Okay, now certain polymorphic variants of this actually confer resistance against Mycobacterium tuberculosis. That means the NRAMP1 may be very efficient in preventing the phagocytosis, and thus even if you have inhaled, you have been exposed to MTB bacilli, you don't develop infection of the macrophages, and thus you don't develop the infection. But certain polymorphic variants are associated with increased risk of developing tuberculosis, where NRAMP1 may be inefficient in preventing phagocytosis. So MTB cell makes its entry into the macrophages, and once inside the macrophages, it has its own inherent mechanisms to prevent destruction, right? So now let us talk about the bacilli which has made its entry into the macrophage. So you have a bacilli which has made its entry into the macrophages. So this entry is done through what we call as phagocytosis, right? Now this phagocytosis, we have to also remember that complements, particularly C3b and C3bi, the complement factors C3b and C3bi actually facilitate this phagocytosis. So our complement system facilitates phagocytosis. NRAMP1 try to obstruct phagocytosis, right? We have to remember that mycobacteria are usually resistant to complement mediated lysis. So this complement kind of ends up opsonizing it. So opsonization occurs because of the complement and facilitates the entry into the cell. So now the mycobacteria is phagocytosed. It is inside a phagosome inside the macrophage, right? So we call this as phagosome. It is inside a phagosome inside the macrophage. Now how macrophage can destroy this bacilli? There are two important mechanisms. The mechanism number one is acidification of the phagosome. So protons are pumped into, H plus ions are pumped into the phagosome. So there is an acidic environment which destroys the mycobacteria. But mycobacteria have a evolutionary mechanism where they can inhibit this acidification of phagosome. Okay, so this acidification of phagosome is caused by a particular pump called as vesicular. Vesicle stands for phagosome, right? So vesicular proton ATPase. It's called as vesicular proton ATPase, or in simple words, VATPase. So this VATPase causes acidification of the phagosome. The mycobacteria produce a substance called PTPase, which will inhibit acidification of, or which will inhibit this VATPase, vesicular proton ATPase, and thus acidification is prevented. So the first insult, somehow it is able to escape. Now what is the second mechanism by which mycobacteria can be destroyed by the host cell? The second mechanism is fusion with what we call as lysosome, right? So there are lysosomes inside the macrophages, lysosomes. So these lysosomes, once they fuse with phagosome, we call it as phagolysosome, right? So this lysosome already contains lysozyme and various other substances which are lethal to mycobacteria. Once they fuse, there is a mixture and mycobacteria are destroyed. If the fusion occurs, even if the acidification has not occurred, it will be able to destroy the mycobacteria. But fusion is prevented by the mycobacteria. There are two factors which prevent the fusion. The second one is phagosome lysosome fusion, right? Lysosome fusion. So this fusion is inhibited by two factors of the mycobacteria. So factor number one is presence of lipoarabinomannan. Okay, so what is this lipoarabinomannan? It's a substance which actually inhibits rise of intracellular calcium. Now how this lysosome and phagosome are getting fused? There is an important role of IP3 DAG pathway in this fusion, right? So we call it as IP3 DAG pathway. So there is a role of IP3 DAG pathway. So there is role of this calcium calmodulin pathway in fusion of lysosome and your phagosome, right? So all this IP3 DAG pathway works by increasing the intracellular calcium, right? So if you inhibit rise of intracellular calcium, obviously the fusion is affected, right? So this lipoarabinomannan inhibits the rise of this intracellular calcium. So once the intracellular calcium increases, the lysosome and phagosome will fuse. Lysosome will inject its stuff into the phagosome and destroy the mycobacterium. So that is inhibited by lipoarabinomannan. That is one substance. There is also a second substance which acts as a defense against fusion. There is another fusion inhibiting factor that is called as COD factor, which is a very important virulence factor. COD factor. Chemically, this COD factor is also a lipid carbohydrate complex. The chemical name would be dimycolate or dimycolic acid trehalose. Dimycolate trehalose. Trehalose is the carbohydrate component and dimycolate is the lipid, right? So on the cell wall, it has this COD factor which acts as an inhibitory factor for the fusion of lysosome and phagosome. So now the bacilli has made its entry into the phagocyte and somehow it has inhibited its own destruction by preventing the acidification and by preventing the fusion of lysosome and phagosome. So inside these macrophages, now these bacilli start replicating, right? So once they start replicating, if the macrophage dies or if they're only restricted to this macrophage, obviously that doesn't serve the purpose. Now they can only infect these cells from the reticuloendothelial system. So they have to recruit more macrophages to start infecting, right? So that is where the additional knowledge of virulence factors comes into picture, right? So I'm talking about two more virulence factors now, apart from whatever I've spoken so far. One is CAT G. I'll come to that in a bit. The other one, particularly right now very relevant for us, is there is a gene on the genome of this MTB that is called as RD1. So this RD1 codes for three important proteins. They are called as ESAT6, CFP10 and ESX1. Okay, so what are these? ESAT10 stands for early secretory antigen 6. Sorry, not 10, 6. Early secretory antigen 6. Right? That is one. Then the second one is, so the CFP10 stands for culture filtrate protein. Culture filtrate protein 10. Okay, and the ESX1 actually stands for, or it codes for, a bacterial secretory system. Okay, these are very, very important virulence factors. I'll talk about it now. So ESAT1 and CFP10 are produced by this RD1 locus, and the ESX1 is a secretory system which actually facilitates excretion or egress of these proteins into the surrounding environment. Okay, why are these proteins important? Particularly, they are usually complex, but particularly ESAT6 is very important. So this ESAT6 stimulate macrophages to produce what we call as matrix metalloproteinase 9, MMP9. Now this MMP9 is the one which is involved in recruitment of, what it does, it causes recruitment of other macrophages, because these tubercle bacilli now need to have other macrophages to infect them, right? So recruitment of other macrophages, so that a second crop of infection can start from the primarily infected cell, right? So this ESAT6 and CFP10 are important for this purpose, recruitment of other macrophages, and the secretion of this ESAT6 and CFP10 are done by this secretory system called as ESX1. Okay, now this absence of ESX1 is particularly important because in the absence of it, the bacteria will find it difficult to cause infection, less aggressive infection, less tuberculoma formation, less granuloma formation, right? If you remember, we use this vaccine called BCG for prevention of TB. So this BCG vaccine is usually derived from M. bovis strain, which is usually lacking this ESX1. So ESX1 is not present in the M. bovis strain used for Bacillus calmette-guerin vaccine. So because of that only, it doesn't cause disseminated infection, but definitely sufficient enough to trigger the cell-mediated immunity. Clear? Okay. Now, the other virulence factor before we move on is this CATG. CATG actually codes for a catalase peroxidase system. Catalase peroxidase enzyme system. Okay. Now, even if the MTB bacilli is able to survive inside the host cell, that is macrophage, by preventing acidification, by preventing fusion with the lysosome, and it is able to replicate and it is able to infect other cells with the help of this ESAT6, CFE10 and the secretory system ESX1, right? Even then the host cells will probably have a very high oxidative stress or oxidative load, right? The infected cells will be going through high oxidative stress. So that oxidative stress itself may be sufficient enough to kill the mycobacteria. So the bacteria needs to have a defense against that. So this catalase peroxidase system coded by this gene called CATG comes in handy. So this reduces the oxidative stress and helps the thriving environment for mycobacteria inside the host cell. And if you remember, when we talk about this INH drug, this CATG is required for activation of INH. So certain mutations of CATG actually confer resistance against INH, right? Clear? So this is the basic pathology or pathogenesis of MTB. So now let us see how human body responds to this infection, right? So macrophages are one set of defense, but once the macrophages are infected, right, human body has to respond to that, right? So we have already understood that there is no much role of the humoral immunity, but there is definite role of cell-mediated immunity. So what is going to be the response? The tubercle bacilli are going to be intracellular organisms. So it usually will trigger a cell-mediated, that will trigger a Th1 response, right? So our response is going to be a Th1 response. So that will lead to activation of our Th1 lymphocytes, right? So once there is a Th1 cells recruited, right? So that is triggering a Th1 response. So what these Th1 cells will cause? The Th1 response will release or result in release of two important cytokines. One is our TNF alpha, the other one is interferon gamma. TNF alpha and interferon gamma, right? So this TNF alpha will cause further recruitment of macrophages. Okay. Now in someone who has got good cell mediated immunity, these macrophages may be able to contain further dissemination of infection. Okay. Then what this interferon gamma will cause? Interferon gamma is basically a vasculotoxic or a vasoactive substance, right? So it can cause vasodilatation and vascular injury, leading to what we know as exudative response, right? So this exudative collection that is seen in and around tuberculosis infected area is primarily loaded with inflammatory cytokines, which can be toxic to human tissues as well as which can be toxic to mycobacteria, right? So all these exudative effusions that we see, exudative tubercular meningitis, exudative pericarditis, exudative pleural effusion, all of them is because of interferon gamma, right? And this TNF alpha will now recruit more macrophages. Now, what is the outcome of all this? Now, bacilli has come, infected macrophages. It is able to survive inside macrophages. It will start replicating and it will start affecting other macrophages. If the immunity is good, these macrophages will try to contain the infection and eventually destroy the mycobacteria. So healing is, as such, I can say, norm in most of the people who have a good cell-mediated immunity. So outcome from this point of time is, once the Th1 response kicks in, the outcome is possibly that you have a infected cell which is now surrounded by other activated macrophages, right? So these are all activated macrophages. Eventually that will lead to destruction of the infected cells and thus you have healing. So first there is a granuloma formation. This granuloma will eventually heal with calcification and fibrosis. That is seen in around 90-94% of the patients. But some patients, right, because of inefficient clearance of this tubercle bacilli, the bacilli will remain active. They will keep replicating. They will try to recruit more macrophages, infect them and kill them. Now, what cell-mediated immunity can do at this point of time is try to restrict this spread of the tuberculosis, right? So this restriction is what we recognize as latent tuberculosis. We will talk more about it later. It will become a little more clear for you. Just right now, be aware about this. Okay, how that works. So you have this infected macrophages at the center. Some of them are dying and they are contributing to what we call as caseous necrosis. Then there is a rim of activated macrophages, and surrounding that, these activated macrophages are the ones which are preventing this further dissemination of tuberculosis, and it is now present in the form of an active granuloma. But this active granuloma, whatever activated macrophages are there, it's like a war zone, right? So you have some macrophages which are active, they are guarding against this infected zone, but some of these macrophages will fall prey to tubercle bacilli. So once these macrophages die, there is need for recruitment of more macrophages, so that it is restricted geographically in this particular region. Infection is restricted geographically. So how these new macrophages are recruited? For that recruitment, we need this TNF alpha. So from where the TNF alpha will come? From the Th1 cells, right? So surrounding this rim of macrophages, you will have another rim in the granuloma, which is comprising of your Th1 cells, right? So core, there is infected macrophages, and the caseous material, end result of the death of those infected cells, that is a caseous necrosis, surrounded by activated macrophages, surrounded by Th1 cells. So these Th1 cells are required for maintenance of this granuloma. In the sense, maintenance of this granuloma sufficient enough to contain the infection. Once the Th1 response dies off, this granuloma, which was latent tuberculosis, now can become active. That's what we call a secondary activation, right? So this TNF alpha is very, very important for sustenance of this in the latent stage, restriction of infection to the granuloma itself and not to spread. So that is why whenever we treat someone with this TNF alpha blocking agents, there is a risk of reactivation of tuberculosis. Once you take out the Th1 response, right? So there is no more new macrophages recruited. Whatever macrophages are recruited, they start getting infected and start dying, and this bacilli can start getting disseminated from one zone to other zone, right? Clear? Okay, so that is about the host response. Now let us see how the disease progresses in an infected person, right? So when someone inhales these contaminated droplets, the first site mostly in most people, it will land up in the right lower lobe of the lung. That is the commonest site. In fact, that is the commonest site for receiving most of the inhaled particles, right? You know, when we talk about the aspiration pneumonia, why it is more commonly affecting the right lower lobe, because the bronchi is much more aligned to the axis of the trachea, so most of the particles will land there. So for inhaled also, that is the most common site. So right lobe of the lower lung, right lower lobe is the most common site where the primary tuberculosis infection can occur. So if someone gets exposed to a positive case, 1/3 of them develop a primary tuberculosis and remaining 2/3 develop what we call as ineffective infection. So what is ineffective infection? The ineffective infection is where the macrophages are not eventually infected. Once the macrophages are infected, right, the tubercle bacilli has found a survival place. From there, either it can get reactivated later or it can cause active infection now. But in this ineffective infection patients, there is no generation of infected macrophages. There is no immune response from the body. Basically, the bacilli do not cause or do not invade the macrophages. Okay. Under what circumstances that can occur? Most importantly, it is the lack of adequate bacillary load, right? So that is one important thing. So we need more than 10:4 bacilli per ml of the sputum to cause infection of the infected person. Only then he will be able to generate droplets having sufficient mycobacteria to cause infection. So inadequate amount of bacilli being inoculated may be one reason why you don't develop the active infection. The second thing is you might have very efficient cell mediated immunity which might clear off the tubercle bacilli before it forms a granuloma. Once it forms a granuloma, once there is a triggering of Th1 response, right, from that point of time, either you have a latent tuberculosis or you get a completely healed tuberculosis. So you definitely have a primary tuberculosis in that case, right? So initial bacilli that came, they're taken care by the macrophages without triggering the granuloma formation. That is a second explanation why you might have ineffective infection, right? So what is the important thing to know about ineffective infection? These patients who have ineffective infection, they are usually TST or the tuberculin skin test negative. They are usually negative. Why are they negative? Because this tuberculin skin test is basically testing what? It is testing our interferon gamma release, right? Interferon gamma release is coming because of what? Th1 cell response, right? So if there is no immune mechanism trigger, if there is no granuloma formation occurring, then there is no Th1 cell response, so there is no interferon gamma release. So thus your TST skin test will be negative. Okay, are these patients infective to others? No, right? These people are not infective to others. So this is also one more point we have to note. Okay, clear? So these ineffective infection patients are going to be TST negative and they are not going to be infective to others. Okay, are they going to be immune to future exposures and infections? No, because the previous exposure has not triggered an infection, not triggered an immune response. They are not going to have any particular protection against future exposure. So if sufficient bacilli land up in their airway in the future, they can develop an active infection. So 1/3 of those who are exposed will develop what we call as primary tuberculosis. As I've already told you, the most common site is right lower lobe. Okay, so there are 2 points to note here. The point number 1 is usually primary tuberculosis is, as I've already told you, it's a parenchymal disease, right? And it is usually subpleural. It's a parenchymal disease and it is usually subpleural, right? So if you note here, I have drawn a subpleural location itself, right lower lobe, subpleural lesion. This is what we call as Ghon's focus, right? The name of this primary tuberculosis focus is called as Ghon's focus. So there at that primary site where the bacilli got inoculated, all the pathophysiological changes that we just discussed in the previous few minutes will start coming into play, right? So there is a formation of granuloma. If the cell mediated immunity is effective, that will cause healing of this granuloma, right? Very often before a granuloma forms or healing occurs, the bacilli might, through hematogenous and lymphatic route, might spread to hilar lymph nodes. So when hilar lymph nodes and your primary focus is involved, when it is coupled with involvement of hilar lymphadenopathy, this is what we call as Ghon's complex. So Ghon's focus and Ghon's complex are part of our primary tuberculosis, right? They're part of primary TB. Now, if the cell-mediated immunity is effective, as I've already told you, there will be a healing response. Healing occurs by destruction of this mycobacteria. Eventually, there is fibrosis and calcification. So once this Ghon's focus or Ghon's complex becomes calcified, right? So this heals by calcification. Once it is healed by calcification, this focus is in that case called as Ranke's complex. What do we call it as? We call it as Ranke's complex. So Ranke's complex is also a primary complex, which is nothing but calcified and fibrosed Ghon's complex. Right? Clear? Okay. Now some patients from the primary Ghon's focus might develop a little bit of dissemination to, like how it disseminated to lymph nodes. It can also disseminate to the right apex. Right apex. As I've already told you, it is parenchymal infection. So right apex parenchyma is affected. And mostly there, when the parenchyma is affected, it is going to be subpleural again. So this another focus, which is again subpleural and parenchymal, is called as, which is at the right apex, subpleural, parenchymal, right apical focus is now called as Simon's focus, right? Clear? We call it as Simon's focus. So this Simon's focus is often called as secondary complex or the secondary focus. This is not the secondary infection. So keep that in mind. Secondary infection is the activation of latent tuberculosis. So you have a primary tuberculosis which either heals with calcification or becomes a latent tuberculosis. There is an active granuloma but walled off by the activated macrophages and Th1 response. So the infection spread is contained, and eventually when the CM cell-mediated immunity drops down, this gets activated, and that's what we call as secondary tuberculosis, right? So this is called as secondary focus or secondary complex. Simon's focus is called as secondary complex because the primary complex is Ghon's complex or primary focus is Ghon's focus. From there is dissemination. As part of the primary tuberculosis infection itself, there is dissemination to the right apex. This is what we call as Simon's complex or Simon's focus. So Simon's focus is also a subpleural apical focus. So these are all primary focus. Okay. Now what is going to be the fate of this primary focus or primary site of infection? So once you have the primary tuberculosis, the fate of this could be like in more than 95% of the patients, it usually heals, right? So there is a granuloma formation, Th1 response kicks in, and it heals with calcification and fibrosis, right? So it ends up becoming what we call as Ranke's complex. Okay, so are these patients going to be tuberculin skin test positive? Yes, all the patients who develop primary TB will be tuberculin skin test positive. All these will become TST positive because once you call it as primary TB, there is a genuine infection and there is involvement of cell-mediated immunity, there is granuloma formation, there is Th1 response triggered, there is interferon gamma release occurring. So if you do this tuberculin skin test, it is going to be positive. Similarly, your interferon gamma release assays, they can be positive in primary TB. Clear? Okay, so 95% is healing with fibrosis and calcification, right? Calcification. So in that case, it becomes Ranke's complex. Now, in some subset of patients, right, it becomes what we call as latent TB. Neither it is healed with calcification and fibrosis, nor it is progressing, right? Then we call it as latent TB. So it is contained infection. These patients are not infective to others, but they have the bacilli, active bacilli present, and anytime this granuloma is now sustained and the infection is contained because of the Th1 response and TNF alpha. So anytime the cell mediated immunity gets depleted, this can get reactivated. So that is the fate of around 3 to 4% of patients, right? So remaining patients usually go on to develop what we call as primary progressive TB. We call it as primary progressive tuberculosis, right? So what is primary progressive tuberculosis? The primary progressive tuberculosis is one where from the Gron's focus there is neither healing nor containment of the infection, so it is progressing. There are two possibilities. One, it could be locally progressive. So locally progressive usually will manifest, or clinically it will come to light in the form of pleural effusion. That's the most common presentation of primary progressive tuberculosis, pleural effusion. So this typical primary progressive tuberculosis occurs in those patients who have poor cell mediated immunity, like HIV infected people, and also children. We have to keep that particularly in mind. Children are vulnerable to develop primary progressive TB, right? Okay, so it can usually present in the form of pleural effusion. Why pleural effusion? So if you remember Gron's focus or any other Simon's focus, these are all subpleural foci, right? So from there can be destruction and release of the bacilli also into the pleural space, as well as this interferon gamma release can facilitate vascular exudation, and that's how we develop this exudative pleural effusion. And apart from that, these patients will have weak cachexia, weight loss, and just classical features of tuberculosis. That's how these primary progressive tuberculosis will come to light, right? Okay, now that is one outcome. Okay, the second possible outcome is much more sinister or much more catastrophic, what we call as miliary tuberculosis. So in miliary tuberculosis, usually there is dissemination of tubercle bacilli from the primary focus to the extrapulmonary sites through either hematogenous or lymphatic spread, right? Either through hematogenous or lymphatic spread. So there is seeding of these bacilli in secondary organs like brain, liver, bone, and various other tissues. Then we will call it as miliary tuberculosis. So miliary tuberculosis is part of the primary tuberculosis. We have to keep in mind it is not the reactivation of the latent tuberculosis. When the reactivation of the latent tuberculosis occurs, we call it as secondary tuberculosis, right? So this reactivation of latent is what is called as secondary tuberculosis. Secondary tuberculosis is often referred as adult type TB, rightfully so, because most of us, particularly those who are living in endemic zones like India, we get infected during our pediatric age, right? So either we have this Ranke's complex forming up, or we have this latent tuberculosis during our adulthood. When something leads to depletion of the cell mediated immunity, we develop this active secondary tuberculosis. That's why it's called as adult type, and the primary tuberculosis is often described as the children type or the pediatric type tuberculosis, right? Okay, now coming back to the miliary tuberculosis. So miliary tuberculosis means there is dissemination through hematogenous or lymphatic spread to other organs, right? So it can cause various foci in other organs also, which we should remember. That's also important for exam. Like this is basics, right? So for example, so far we have learned about this Ranke's complex, Gron's complex, and Simon's focus, right? So now let us talk about the miliary tuberculosis leading to certain foci, and also when the secondary tuberculosis occurs, right? It need not always be reactivation of the primary pulmonary focus. So we have to also keep in mind that when the primary tuberculosis occurs, there is also subclinical or very subtle dissemination of these tubercle bacilli to other organs. There may be seeding, but very negligible or minimal, but reactivation from those sites can also occur, right? Particularly lymph nodes are the most common site for secondary tuberculosis, we all know, right? Okay, so here are the list of important nomenclature or eponyms of TB foci that I want you to remember. Primary we have already addressed. Gron's focus, where is it present? It is subpleural parenchymal lesion, mostly present in the right lower lobe, right? That's the primary focus. When you add hilar lymph nodes to it, it becomes Gron's complex, and when that heals with calcification and fibrosis, that becomes our Ranke's complex, right? and from the Gons focus, when there is hematogenous dissemination to the right apex, we call it as Simon's focus, which is also a primary focus, right? There is one possibility of MCQ from this. They might ask which one of the following is a primary focus, or which of the following is a secondary, or which of the following is a component of the miliary foci, right? So this is one more MCQ that can be asked. So Simon's focus is a primary TB foci, right? Okay, so we were just talking about miliary tuberculosis. So widespread dissemination of tubercle bacilli from the primary focus, part of the primary tuberculosis itself. It's a primary progressive tuberculosis, right? So one of that focus is called as rich focus, which is a focus of the brain or CNS tuberculosis. Rich focus is the focus of CNS tuberculosis. Then we have another focus, the dissemination to subintimal regions of the pulmonary vein, mainly pulmonary vein, other vessels also, mainly pulmonary vein, subintimal pulmonary vein site. We call it as Weigert's or Weigert's focus. Right? So we have to remember one point. This tubercle bacilli, because they primarily affect reticuloendothelial system, they have a tendency to also affect vessels, or they can cause vasculitis. So tuberculosis, CNS vasculitis, is one of the important reasons for what we call as watershed infarcts, right? So we have to keep that in mind. Tuberculosis vasculitis is a common CNS complication, right? So they can also affect pulmonary veins. Then in that case, we call it as Weigert's focus. Now there is one more focus, part of this miliary focus, that's it's called as Simon's focus or Simon's focus, which is the focus in liver. We call it as Simon's focus. So Simon's focus is in liver, and Simon's focus is in the right apex, which is also called as secondary complex. Okay. Now coming to secondary tuberculosis, where it is usually mostly because of reactivation of latent tuberculosis. Sometimes it could be acquisition of infection in the adulthood, but that's like an endemic country, that's less of a contributor. Mostly it is the reactivation of the primary foci itself, right? So we have one thing called as Puel's focus, and the other one is called as Assman's focus. These two things we need to remember for secondary. What is Puel's focus? Puel's focus is where there is reactivation of tuberculosis, mainly affecting, like it is that Simon's focus. You can compare it to that. Simon's focus, if it gets reactivated, you can believe it to be a Puel's focus. So what is happening in Puel's focus? There is a subpleural parenchymal reactivation. Subpleural parenchymal reactivation. So on the X-ray, this reactivated zone, or on the imaging, it would look like there is tuberculous focus in the supraclavicular region as well as in the infraclavicular. So it is the right apex which is most commonly affected here. So obviously it is the right apex which is most commonly affected, and on the X-ray it often looks like a supraclavicular lesion because it is a subpleural lesion. So it is like it will be very close to the pleura, so it will appear a supraclavicular lesion. We also have another reactivation, another focus which is called as Assman, which is a deep-seated right apical focus. Deep-seated right apical focus. Because it is deep-seated, on the imaging it looks like infraclavicular lesion because it is there in the right apex, but it is deep-seated. If it is close to pleura, it will appear supraclavicular. If it is deep-seated, it will appear infraclavicular. So our Assman focus is an infraclavicular focus, which is mainly deep-seated in the right apex. These are secondary tuberculosis, right? Clear? These are some images which actually show about some of these complexes. So in the first image, what you see here is a subpleural, right? We can clearly see that it is a subpleural location, parenchymal lesion, which is calcified. It is evident on the X-ray, that means it is calcified, and you can also appreciate a hilar lymph node which is calcified. So what is this? This is definitely a complex because there is a lymph node as well as the parenchymal focus, and because they are calcified, we have to call it as Rehnke's. So it is really difficult to appreciate Ghon's focus on the chest X-ray. If you do a CT, maybe you will be able to appreciate, or when you have histopath specimens, maybe you will be able to appreciate, but it is really difficult because granulomas are not easily picked up on the X-ray, right? But this calcification can be picked up, so we are seeing Rehnke's complex. Another image where you can see Ghon's complex which is healed. So again, one more Rehnke's complex, lymph node and Ghon's focus. So we have another Rehnke's complex, right? Okay, so now before we wind up, just let us take a quick recap of the important virulence factors. So foci we have discussed about the pathogenesis. Now for us, these virulence factors are going to be very important MCQ areas. So their role and where are they present is an important thing. So first thing I'm talking about is what we call as cord factor. As I've already told you, it inhibits the fusion of phagosome and lysosome. Another factor that inhibits the fusion of the phagosome and lysosome is lipoarabinomannan, which inhibits our IP3 DAG pathway. Thus, increase in the intracellular calcium is inhibited, and thus there is no fusion of lysosome and phagosome. Okay. Then the third factor I'm talking about is CATG, which is a gene actually, right? It is a gene which codes for catalase peroxidase system, which prevents reactive oxygen mediated injury. So it is a defense against the oxidative stress of the host cell. Okay. Third, and particularly according to me, the most important virulence factor is this RD1 locus on the bacterial genome, which codes for these three important substances. Right? Early secretory antigen 6, then your CFP10 and ESX1. Right? So this ESAT6 and CFP10 complex is involved in recruitment of uninfected macrophages for further round of infection. Right? And this recruitment is facilitated by expulsion of these molecules by this secretory system called as ESX1. This is the secretory system that is involved in expulsion. Okay. The last virulence factor we need to know is V-ATPase. So this V-ATPase is, okay, I shouldn't be calling V-ATPase as a virulence factor. It is, the virulence factor is actually PTPase. So V-ATPase is one which is involved in acidification of the phagosome, and this PTPase inhibits the acidification of this phagosome. So this is in essential summarizes all the basics we need to know about the tuberculosis. Having understood the pathophysiological process of tuberculosis infection, now it's time for us to learn about the clinical features. This is going to be a very succinct review because we recognize tuberculosis as a great mimicker or one of the great masqueraders, just like syphilis and other infections. This is also one of the great mimickers. It can affect various organs, and every organ in itself is a topic of great discussion, right? So we can spend hours and hours talking about, say, tuberculosis meningitis or tuberculoma or spinal tuberculosis. Everything in itself is a major topic, but that's definitely beyond the scope of NEET SS general medicine. So keeping true to the NEET SS, we will be discussing clinical features. So whenever we talk about tuberculosis, the first thing that comes to my mind is constitutional symptoms, because from our MBBS days itself, we have been trained to talk about fever, evening rise of temperature, right? I think that's one of the very earliest negative history that we take from the patients when we go to the bedside discussion, right? Do you have fever and do you have evening rise of temperature, right? So fever is in fact the most common constitutional symptom of tuberculosis. Be it pulmonary tuberculosis, be it extrapulmonary tuberculosis, this can occur. Fever can occur. Fever is usually low grade, and this traditional description of evening rise of temperature is quite less appreciated in today's context, because patients start taking antibiotics before they start coming to us, and similarly they start taking maybe quinolones and other antibiotics before they reach out to a physician for diagnosis. So it is less appreciated, but we should be still aware about it. Okay. Now, apart from fever, what is the other important constitutional symptom? Weight loss. So when it comes to India, right, whenever someone presents with unintentional weight loss, I think the first thing that we think of is tuberculosis, and then we start thinking about malignancy and other chronic inflammatory disorders as cause for weight loss, right? So weight loss is also a very, very important constitutional symptom that we see in patients with tuberculosis. Now, rest of the symptoms and clinical features of tuberculosis will obviously depend on the affected organ. Starting with our pulmonary tuberculosis, whether it is primary pulmonary tuberculosis or post-primary, what is the most common complaint of these patients? Cough, which is often chronic, lasting for more than 2 weeks, is the most common pulmonary tuberculosis complaint, right? Now, this cough initially may be dry cough, but eventually more than 80% of the patients will start becoming productive, right? More than 80% of the patients of pulmonary tuberculosis generally have productive cough, right? Okay, so cough is a complaint. Apart from that, yeah, I have to tell you that cough is usually, at least in the initial phases, it is more common in the morning hours. It's more common in the morning hours, but eventually the cough starts becoming common in the evenings and other part of the day, right? Okay, now cough is one symptom. Some of these patients might present with hemoptysis. So hemoptysis could be because of the parenchymal destruction, and also it could be because of vascular invasion. So particularly when we talk about vascular invasion in a cavity, right, tuberculosis can erode to reach out to pulmonary vessels. So small pulmonary vessels, tributaries, that is often recognized as, so it leads to vascular invasion of the small pulmonary vessels, leads to what we call as Rasmussen's aneurysms, right? Rasmussen's aneurysm. So we have to keep in mind that if it is the Rasmussen's aneurysm that is bleeding, patients are not likely to present with massive hemoptysis. So if a tuberculosis patient presents with massive hemoptysis, it is most likely because of the tubercular granulomas invading the systemic circulation, the blood vessels from the systemic circulation or the bronchial vessels, not because of the pulmonary vessels. Pulmonary vessels are a low pressure system. You talk about pulmonary artery or pulmonary veins, they are low pressure systems. So if they start bleeding, it causes submassive hemoptysis. If it is massive hemoptysis where patients present with hypertension or patient present with more than 400 ml of expectoration in 24 hours or 100 to 200 ml in a single bout of expectoration, that is what we call as massive hemoptysis, which is like not so common when it comes to tuberculosis, though still in India it continues to be the most common cause for massive hemoptysis. We should keep in mind that it is not very common in tuberculosis, right? Because bronchial vessels are less commonly invaded, it's most commonly invaded, the pulmonary vessels are most commonly invaded, right? So Rasmussen's aneurysm is an aneurysm of the pulmonary vessels, not the bronchial vessels. Okay. Then the third thing that can occur in these patients is these patients might develop cavities, right? So when the tuberculosis occurs, there is a tuberculoma granuloma formed, which will eventually heal with fibrosis calcification, or sometimes it can heal with a cavity formation. Now this cavity often might develop into what we call as aspergilloma. So aspergillus fungal ball may form in these cavities, right? So these aspergillomas can be of two types. One is called as simple aspergilloma, the other one is called as complicated. So these simple aspergillomas are usually asymptomatic, right? They are usually asymptomatic. But these complicated aspergillomas, as we all know that aspergillus spores have a tendency to invade the vessel. So they are like they have a higher specificity to invade the blood vessels. So because of that, they can invade the blood vessels and cause hemoptysis, right? So complicated aspergillomas can often present with hemoptysis, right? So in fact, in one of the recent NEET SS question, there was a bit of a controversy. There was a question asking what is the most common presentation of aspergilloma. According to me, that's a bland question, because so today we have started recognizing these aspergillomas as simple and complicated, right? And today most of the cases of aspergilloma are complicated rather than simple. So like the logic is this: now whenever you have an aspergilloma, aspergillus is not going to sit quiet. When you have a cavity and when there is a fungal wall, this aspergillus species is not going to sit quiet. It will definitely be angioinvasive. It will try to invade the blood vessels and eventually it will cause hemoptysis. So if at all you incidentally detect an aspergilloma in someone, it is just that near future patient might present with hemoptysis. Right now you have caught him before there is obvious evidence of angioinvasion, right? So most of these patients come to light because they start developing hemoptysis, not because you randomly screened people with imaging. So according to me, if there is a question asking you what is the most common presentation of aspergilloma as such, I would still prefer to go with hemoptysis as the right answer. If you look at all the recent papers, they mention, all the recent literature and textbooks, they mention hemoptysis as the most common feature. Simple aspergillomas are less common than the complicated aspergillomas. If the question specifically asks you what is the most common presentation of simple aspergilloma, maybe then you can think of asymptomatic, right? Okay, so this again leads to hemoptysis. So cough and hemoptysis are two important clinical features of pulmonary tuberculosis. So beyond that, when pulmonary tuberculosis is miliary, patients might present with respiratory distress and hypoxia. Similarly, beyond this pulmonary tuberculosis, if there is a pleural tuberculosis along with pulmonary tuberculosis, then there may be there may be significant or massive pleural effusion, which is often exudative. So because of that, patients might again present with respiratory distress. So that's also a possibility that we need to keep in mind. So this is about the pulmonary tuberculosis. The primary and the post-primary, we have already discussed about it in the pathophysiology itself, right? Now talking about the extrapulmonary tuberculosis. Yeah, before we go to the extrapulmonary tuberculosis, let us take a quick look at some of these images. Now before we go to discuss the extrapulmonary tuberculosis, let us take a quick look at some of the images of pulmonary tuberculosis. So this is the first image that I am trying to project here. So in this image, what can we appreciate? We can appreciate a cavitatory lesion in the right apical lobe, as well as we can appreciate a cavitatory lesion in the left apical lobe. As of now, I don't see any fungal ball in this, but we should be able to identify if it is there, right? Okay, so the same patient's CT thorax clearly identifies a cavity, one cavity in the right apex, another cavity in the left apex, and you can also see some amount of fibrotic process affecting there. right? The same patient's another view of X-ray, you can clearly appreciate the cavities. Definitely there are no fungal balls, and you can appreciate some degree of fibrotic process. Okay, that is one. Okay, the second thing here what we see is actually this is a patient with pulmonary tuberculosis with endobronchial TB, endobronchial tuberculosis, right? So as I've already told you, pulmonary tuberculosis is primarily a parenchymal disease, but sometimes when particularly a lymph node, paratracheal lymph node, pretracheal or paratracheal lymph node, when it granulates, caseates and ruptures into the airway, ruptures into one of the bronchial branch or into the major airway, right, it can cause infection of the airway, right? That is what we call as endobronchial tuberculosis. So this is a patient with endobronchial tuberculosis where you will see that there are multiple granulomas present. Now these granulomas in a typical case of pulmonary TB are usually centrilobular. They are usually centrilobular. So when there are multiple centrilobular granulomas and you have a bronchial tree which is loaded with caseated material, endobronchial tuberculosis is what I am talking about, which is loaded with caseous material and exudative material. In such cases, it gives rise to what we call as tree in bud appearance, right? It gives rise to what we call as tree in bud appearance, often appreciated on CT, not on X-ray. We should keep in mind that tree in bud appearance is not specific for pulmonary tuberculosis. It can be seen in interstitial lung disease and various other conditions like bronchiectasis, right? In fact, the first description of tree in bud appearance actually comes from patients with endobronchial tuberculosis, but eventually then we started noticing that in patients with bronchiectasis and interstitial lung disease. We have discussed a lot about it when we discussed the investigations in pulmonology. You can definitely watch that video, right? So what is this tree in bud appearance? So you have these centrilobular granulomatous lesions and the feeding bronchial tree is loaded with caseating material and exudative material. So because of that, it also becomes opaque. So it gives rise to this tree in bud appearance. So in this image, you can appreciate that tree in bud, typical tree in bud appearance, right? So this is the tree and branches, right? And you can appreciate all these granulomatous lesions here, right? These are all centrilobular granulomatous lesions, centrilobular granulomas. These granulomas are often small, tiny. They are usually 2 to 4 millimeters, sometimes slightly more than that, right? Clear? Now this is particularly important because I'm repeating these words centrilobular multiple times. The reason for that is we also see multiple granulomas, tiny granulomas in patients with miliary tuberculosis, another form. It is actually a form of the primary tuberculosis, right? So in miliary tuberculosis, we see multiple granulomas just like how we see in the primary pulmonary tuberculosis or the post-primary pulmonary tuberculosis, which is not miliary. The main difference between these two is in miliary tuberculosis, all these granulomas are much more tiny, right? The name or the word miliary comes from the fact that they are all believed to be millet sized, and their distribution also is like when you throw millets on the floor, the distribution is quite random. So this distribution here is also random. It is not centrilobular. It is randomly distributed granulomas that we see in miliary tuberculosis, right? Let me show you an image if I have. This is one more image where you can appreciate the tree in bud appearance, right? So the tree branches and these granulomatous budding region. So tree in bud appearance, right? Okay. So this is an X-ray of a patient with miliary tuberculosis. As you can appreciate, right, there are very tiny granular granulomas, right? Very tiny, fine granular granulomas. They are usually 1 to 4 millimeters in size, and they are randomly distributed. As I have already told you, they are not centrilobular, right? Often when you see this the miliary tuberculosis patients, often they might present with respiratory distress and hypoxia, and sometimes it may be difficult to distinguish between ARDS and miliary tuberculosis unless you start finding that there is also other organ involvement in the form of granulomas, and then you start becoming little certain that it is a case of miliary tuberculosis, right? Okay, so that was about the pulmonary tuberculosis. Now let us talk about the extrapulmonary tuberculosis, right? Starting with involvement of lymph node. So what is the lymph node involvement? Is the most common site, most common extrapulmonary site for the tuberculosis. In fact, there are 3 important extrapulmonary sites for tuberculosis in their decreasing order. You can remember it with the mnemonic LPG, right? So lymph nodes is the most common, that is seen in around 35% of the patients with tuberculosis, followed by your pleural, right? So pleural is seen in around 20% of the patients with tuberculosis, then followed by your genitourinary tract, right? Genitourinary tract, which is seen in around 15% of patients with tuberculosis, followed by skeletal muscle system, followed by meninges, followed by your peritoneum and the GIT, followed by your pericardium, right? So this is the decreasing order of extrapulmonary site involvement in patients with tuberculosis, right? Lymph node is the most common. This is one of the frequently asked MCQ. So whenever we talk about lymph node tuberculosis, we should describe this in few words. So lymph node tuberculosis, most commonly affected lymph nodes are usually your posterior cervical lymph nodes and your supraclavicular lymph nodes, right? Supraclavicular and posterior cervical lymph nodes are the most commonly affected lymph nodes, right? Now, these lymph nodes to start with may be discrete, but eventually multiple lymph nodes, they get matted together. So when you examine, majority of the patients will have matted consistency of lymph node examination, and the tubercular lymphadenopathy is usually painless. They don't present with pain. They are usually painless, right? Okay, so is that clear? Now MCQ wise, they might ask you, what is the investigation of choice for confirmation of diagnosis of tubercular lymphadenopathy? Obviously, it has to be a microbiological study. So you can either consider FNAC or open biopsy. Now FNAC may be adequate for the diagnosis of lymph node tuberculosis. In more than 80% of the cases, it will be diagnostic. In some cases where the confusion still prevails, you can go with the open biopsy. So to start with, the starting point is usually FNAC, right? Now, once you get the sample, what test you would prefer to do, right? You have options of doing molecular methods like CBNAT, or you can culture, or you can do the acid-fast stain. Now, acid-fast stain, when it comes to lymph node tuberculosis, is not very sensitive. So that is not what is routinely practiced. So what we follow, either you can follow culture and sensitivity, or you can follow your gene expert, right? One of the government recommended CBNAT method. So gene expert can be considered as the investigation of choice. It is reasonably sensitive. It is sensitive in more than 80% of the cases. Culture can be considered as gold standard, but routine starting point is gene expert. So you suspect that patient is having tubercular lymphadenitis because he presented with cervical lymph nodes or supraclavicular lymph nodes. They are matted in consistency when you examine. Now you do an FNAC, and then you subject the FNAC sample for either culture or gene expert. Mostly you start with gene expert, and if in doubt, or you want to be doubly sure, maybe you can send the sample for culture also, right? Okay, so let us look at some images of the tubercular lymphadenitis. So this tubercular lymphadenitis, externally it appears in the form of what we call as scrofula or scrofulum. What is scrofulum? Which is nothing but an inflamed tubercular lymph node that can be seen externally. When this scrofulum, so this is also a scrofula, and what we see here is also scrofula. Now when this scrofula, this inflammation and infection which is restricted to multiple mated lymph nodes, if it spreads to or spills over to skin, then we call it as scrofuloderma. Right? So this scrofuloderma is what we can see in this image, right? So there are lymph nodes that you can appreciate, and also inflammatory changes in the skin. Okay, you should also keep in mind that some of these lymph nodes might also develop or fistula, and from the fistula you may be able to even appreciate the caseating material draining out, right? So this is about the tuberculosis of the lymph node. Now before we move on, there are 2 or 3 important points I want you to remember. The point number 1 is MTB is not the sole cause for scrofula or scrofuloderma, right? So scrofula or scrofuloderma or tuberculous lymphadenitis can also be caused by, apart from our MTB, it can also be caused by our M. bovis. In fact, in the past, M. bovis used to be the most common cause. Now it has been replaced by MTB. Okay. Apart from that, there is also a non-tubercular mycobacteria that can cause, that is our Mycobacterium scrofulaceum. Name itself gives out the clue. Mycobacterium scrofulaceum can also present with scrofula and scrofuloderma. Right? Clear? So that's about tubercular lymphadenitis. Now, the second most commonly affected extrapulmonary site is pleura, right? This is the second most commonly affected site. So this pleural tuberculosis may be associated with pulmonary tuberculosis or may be not associated with pulmonary tuberculosis. Similarly, when we talk about lymphadenitis, right, tubercular lymphadenitis, less than 50% of the patients will have evidence of pulmonary tuberculosis at the time of diagnosis. So remaining 50%, you don't see any evidence of pulmonary TB at the time of diagnosis. This is restricted to extrapulmonary site, right? Similarly, less than 50% of patients will only have evidence of pulmonary tuberculosis when you diagnose them with pleural tuberculosis. So how pleural tuberculosis presents? Patients with pleural tuberculosis will usually present with pleural effusion, right? They will usually present with pleural effusion and the symptoms related to that, right? So patients might have pleurisy, patients might have respiratory distress depending on the volume of fluid collected. Okay. Now, the diagnosis of pleural tuberculosis obviously depends on microbiological studies, right? And when we talk about microbiological studies, obviously we have to prove that there is a tubercle bacilli present, right? So your pleural fluid analysis can only be a potential clue. You cannot be very certain about the diagnosis of tuberculosis based on the pleural fluid analysis. So when we do pleural fluid analysis, what we notice, it typically causes exudative effusion, right? It causes exudative effusion. So when you apply the Lights criteria, you notice that it is exudative pleural effusion that we're talking about, often associated with low, maybe normal, but most cases it is low pleural fluid glucose, low pleural fluid glucose that we see. pH is usually around 7.3. When the pH is very low or acidic, we might start thinking of either secondary bacterial infection or per se the effusion may be caused by an empyema rather than tuberculosis. But sometimes even in the absence of infection, it can present with pH less than 7.2, but in most cases it is around 7.3. The pleural fluid pH is around 7.3 or slightly higher. Okay, then the pleural fluid will show increased WBC counts. Initially, it may be neutrophil predominant, but eventually most cases will become lymphocyte predominant, right? Most cases will become lymphocyte predominant. It is not unusual to see lymphocytes as high as 95% of the total WBC count that we would see in these patients, right? Okay. Now, one potential clue that comes for the diagnosis of pleural tuberculosis is in the form of ADA levels, right? So ADA levels more than 40 are potentially diagnostic of pleural tuberculosis effusion, and less than 34 may be helpful in ruling out the diagnosis of pleural TB, right? Clear? Okay. So that's about the pleural tuberculosis. Now the next organ we are talking about that is affected is our genitourinary tuberculosis. So genitourinary tuberculosis typically we suspect when patient present with sterile pyuria, in acidic urine. So patient is having pyuria, cultures are not giving anything, multiple cultures not growing anything, and the pH of the urine is on the acidotic side. You start suspecting the possibility of genitourinary tuberculosis. So when we talk about genitourinary tuberculosis, any organ or any structure part of the genitourinary system can be affected, right? So your kidneys can be affected, your ureters, your bladder and your post bladder structures, and when we talk about females, even endometrium and fallopian tube can be affected, right? So in fact, genitourinary tuberculosis is more common in females than males. It's more common in females than males, and in females, because endometrium and your fallopian tube can be affected, it is one of the important reasons for infertility in India, right? It can also result in infertility, right? Okay, how most of these patients of genitourinary tuberculosis present? One way of presentation is the sterile pyuria. Apart from that, some of these patients might present with hematuria and lower abdominal pain. Hematuria and your lower abdominal pain, that can be a usual presentation, right? So there are three important points to remember. One is sterile pyuria. The second is females are more affected than males and it can be responsible for infertility. The third is they can present with hematuria, right? That's about the genitourinary tuberculosis. Okay, now talking about the skeletal tuberculosis. When we talk about skeletal tuberculosis, right, there are usually involved sites are weight bearing joints. So most commonly affected skeletal structure is spine. That is the most commonly affected, followed by your hip joint, followed by your knee joint, right? So this is also one more important MCQ point. Spine is the most commonly affected joint, right? So when we talk about skeletal tuberculosis, we should keep in mind that skeletal TB most commonly affected is, as I've told, is the spine. And when we talk about the involvement of spine, right, we should note that in children usually upper thoracic vertebrae are affected. Upper thoracic vertebrae are affected, but in adults it is usually lower thoracic vertebrae or lumbar. Either lower thoracic vertebrae or lumbar vertebrae are affected. Okay, so what is the usual involvement? Usual involvement in spine can be in the form of, most commonly affected site is actually your what we call as paradiscal lesion. Paradiscal lesion, that's the most common spinal lesion. Now what is paradiscal lesion? If you look at this spinal arrangement, right, all these vertebral bodies are arranged like that, and in between these vertebral bodies we have the discs, right, and you have posterior integumental structures. Now when these tuberculomas form just adjacent to these discs, we call them as paradiscal. This is called as paradiscal lesions. So these are the most common types. Okay, apart from that, sometimes the second most common is usually in the form of what we call as central lesion. So central lesion is where the lesion is deep seated in the vertebral bodies, mostly away from the paradiscal region. This is our paradiscal region, right? So when it is away from it, close to the center of the vertebral body, we call it as central spinal tuberculosis. Okay, apart from this, even the anterior part of the spine can be affected, then we call it as anterior, and sometimes these posterior structures are affected. That is the least common, and we call, in that case we will call it as posterior spinal tuberculosis, right? So MCQ wise they might ask you what is the most common type, that is paradiscal lesion. Okay, now particularly the central lesion often causes destruction of the vertebral bodies, and because of that these vertebral bodies can collapse onto themselves, leading to what we call as kyphosis or gibbous formation, right, leading to formation of gibbous. Apart from that, from here it can also cause, paradiscal spread can also cause formation of cold abscesses, which we all know as an important entity from our MBBS days itself. So spinal tuberculosis causing destruction, gibbous, kyphosis, as well as cold abscesses. These are the presentations. Now some of these patients might present with paraplegia, either because of disc or inflammatory changes causing compressive effect on the spinal cord. They can present with paraplegia. In fact, one of the important cause for paraplegia in India, right? It is one of the important cause for paraplegia in India, right? Okay, so that is about the skeletal tuberculosis. Now coming to the next organ that can be affected, we are talking about gastrointestinal tuberculosis. So when we talk about gastrointestinal tuberculosis, we have to keep in mind that the gastrointestinal tuberculosis, they might ask what is the most commonly affected site. The most commonly affected site, we all know, it is the ileocecal junction, right? Why the ileocecal junction is most commonly affected? Two reasons. One, there are abundant number of Peyer's patches. So if you remember when we were discussing the pathophysiology, I told tuberculosis primarily is a disease of the reticuloendothelial system. So because there are abundant number of Peyer's patches present, abundant number of macrophages present, right, obviously that site becomes the most common site for involvement. The second important reason for involvement is the intestinal peristalsis slows down significantly at the point of terminal ileum, where the food is moving from the terminal ileum into the colon. So because of that slowness, there is increased amount of contact time. The contact time between the mucosa and the food bolus, which is carrying these tubercle bacilli, is high, right? So because of these reasons, ileocecal junction is the most commonly affected site. Clear? Okay. Now how these patients will clinically present, those who have developed ileocecal tuberculosis, right? There are actually two types of presentation. One is what we call as an ulcerative ileocecal TB, and the second one is our hyperplastic ileocecal tuberculosis. Okay, ulcerative ileocecal tuberculosis is most often caused by MTB infection. So remember we were also discussing about this M. bovis as a cause of intestinal tuberculosis, right? So M. bovis often presents with this hyperplastic form of tuberculosis, where there is formation of these tuberculomas which become obstructive. So these hyperplastic TB patients might present with intestinal obstruction, and these ulcerative forms of tuberculosis might present with constitutional symptoms, weight loss, fever, then diarrhea, abdominal pain, right, and sometimes anemia. These are the usual presenting features of patients with ulcerative forms of tuberculosis, right? So they can present with constitutional symptoms and diarrhea. They can also present with hematochezia, and very often these patients are misdiagnosed as Crohn's disease, right? So there is a high risk of misdiagnosis of these patients as Crohn's disease. Very often they are misdiagnosed as Crohn's disease. There are various reasons why. One is that these patients might have multiple ulcers in those regions, particularly in the terminal ileum region. They can have multiple ulcers. That's one reason. The second reason why this is often mistaken as Crohn's disease is sometimes histopathological features may be difficult to distinguish between TB and Crohn's. And third thing is when you look at the radiological features, like you know the string sign of Cantor and various radiological signs that we describe in Crohn's disease can also be seen in patients with the tuberculosis. So because of that, it is often mistaken as Crohn's disease, right? So we should, particularly in India, keep in mind that whenever someone presents with the diarrhea and hematochezia, and we should keep in mind that tuberculosis remains a relevant differential diagnosis. Okay. Now, these ulcerative forms of tuberculosis, there is one more point I want you to note. When you do look at these ulcers under the colonoscopy or endoscopy, you will notice that these ulcers are usually transverse, in the sense their long axis is in the horizontal plane, right? Why this is important? Because when we talk about ulcers in patients with intestinal salmonellosis or typhoid, right? So typhoid perforation is very common. The same location is most commonly affected, terminal ileum, right? So the typhoid ulcers are usually vertical, right? So they have a longer axis vertically aligned with the intestine in comparison to the ulcers that we see in tuberculosis, where the long axis is horizontally aligned, right? Okay, so that is about the intestinal tuberculosis. Apart from the intestinal tuberculosis, these patients can also develop. So when we talk about JIT, the intestinal tuberculosis is not the only thing. These patients can develop peritoneal tuberculosis. Peritoneal tuberculosis. So peritoneal tuberculosis can lead to development of ascites. So when we talk about ascites here, it is usually associated with low SAG score, because this is not a portal hypertensive cause for ascites. So the SAG score will be low and it will be associated with high protein. So this is a typical exudative ascites that we are talking about. Okay. Apart from that, some of these patients can develop fibrotic changes. So because of that, sometimes they can present with abdominal cocoon, right? What we call as abdominal cocoon. That can also be a presenting feature of gastrointestinal tuberculosis or abdominal tuberculosis, right? Okay. Now let us look at the other organ involvement. So we have already spoken about lymph node, pleural, skeletal, genitourinary, and gastrointestinal. Now let us talk about the tuberculous meningitis and tuberculoma. We're not going to discuss it in detail because it's beyond the scope and it will be well dealt when we talk about the tubercular meningitis per se, right? So let us now talk about TB meningitis succinctly. What are the important points I want you to remember? The first point I want you to remember about TB meningitis is that it is usually an exudative meningitis and it causes chronic meningitis. Often these patients present with headache and meningism signs. And when we look at their CSF is the most important modality for diagnosis. When we look at their CSF, we will see that it is associated with increased CSF protein and then decreased or normal CSF glucose, and there may be initially, as I've already told you when we were talking about pleural effusion, initially like first few days it may be neutrophilic predominant, but eventually it becomes lymphocyte predominant CSF picture that we see, right? Lymphocyte predominant picture. ADA levels here also may be elevated, and most of the books mention ADA level more than 10 may be highly suggestive of tubercular meningitis, right? Okay. Now, what is the definitive test? So CSF should ideally be subjected for CBNAT, or your what we call as gene expert. That is considered as the ideal investigation for diagnosis of CSF, tubercular meningitis in the CSF, right? Okay, so that is one thing, chronic tubercular meningitis. Apart from that, some of these patients can develop tuberculomas, which are nothing but granulomatous parenchymal lesions of the brain, which can present as a space occupying lesion associated with raised intracranial pressure, headache, and other symptoms, or they can present with seizures, or they may remain asymptomatic, right? So these are the usual presentations of tuberculoma. The more of it we will discuss when we talk about the meningitis, CNS tuberculosis and CNS meningitis as a separate topic, right? Okay, so that is about the another site of extrapulmonary involvement. Now going on to the last few extrapulmonary sites. Yes, tuberculosis can also cause pericarditis, which is very rare as such. But when it comes to significant pericardial effusion, or as an important cause for pericardial tamponade in India, the first thing that should come to our mind is tuberculous pericarditis itself, right? So in India, this is the most common cause for tamponade. Tuberculous peritonitis is considered as the most common cause for the cardiac tamponade. In the Western world, it is malignancies leading to secondaries to the pericardium is the most common cause for cardiac tamponade. In India, it is the tubercular peritonitis, right? Sorry, tubercular pericarditis. Then coming to the skin lesions. Skin lesions, one thing we have already discussed, that is scrofula and scopuloderma. Beyond that, it can also cause something called as lupus vulgaris. Lupus vulgaris is a cutaneous form of tuberculosis, right? So this lupus vulgaris is predominantly affecting the face, eyelids, and other structures around the neck. So that is why it like gives rise to a vulgar appearance. That's why it's called as lupus vulgaris, right? So let us see if we have some of these images to look at. I think the scrofula and the scopuloderma we have already looked at. So this is a image traditionally often quoted in literature. This is the image of a patient suffering from your cutaneous tuberculosis, what we call as lupus vulgaris. As I've already told you, face is most commonly affected structure, so one has to keep in mind face and facial structures are most commonly affected. We call it as lupus vulgaris. So we should not confuse lupus vulgaris and lupus pernio with the SLE cutaneous manifestations, right? So lupus pernio we see in patients with sarcoidosis, and lupus vulgaris we see in patients with cutaneous tuberculosis, right? Clear? So it's now time for us to talk about the diagnosis. Now, in a country like India, where tuberculosis is highly endemic, a lot of patients are treated even before we arrive at the microbiological diagnosis. Like, we may not be able to arrive at the microbiological diagnosis, but the clinical context makes us strongly suspect that it is a case of tuberculosis, and empirically we start them on the treatment. So in that case, we have the diagnosis which is on clinical grounds, clinically probable tuberculosis. But we should always aim for achieving a microbiological diagnosis. That should be our goal, right? So in the right clinical context, if you're not able to find a microbiological evidence of tuberculosis infection, you might still consider treating empirically. But we should keep in mind that microbiological diagnosis is our goal. Microbiological diagnosis is our goal. Okay. See, what are the important clinical circumstances where you can strongly predict that it could be tuberculosis even in the absence of microbiological diagnosis, and you can initiate empirical treatment? Number one, like in an endemic country like India, where someone presents with typical chest X-ray finding. What is the typical chest X-ray finding we are talking about? Mainly the right upper lobe or maybe even left upper lobe involvement presenting with a cavitatory lesion in that location. Cavitatory lesion may be with consolidation or fibrotic changes. Right? For all practical purposes, until and unless proven otherwise, for me or for most of the Indian physicians, this is a case of tuberculosis. Right? Even if this patient's sputum comes negative, even if we are not able to prove that there is a microbiological evidence to say that there is active tuberculosis, right? If the disease seems to be active, I would be happy to treat this patient with empirical antitubercular agent, right? So that is a diagnosis based on clinical grounds. Similarly, patients with HIV, it may be really difficult to arrive at the microbiological diagnosis, and you might consider based on the clinical grounds to start them on empirical treatment, right? Okay, but as I've already told you, the goal should be to achieve at the microbiological diagnosis. So to arrive at the microbiological diagnosis, what are the tools we have? The laboratory tests that can be used for microbiological diagnosis can be broadly grouped under 4 types. Okay, so the type number 1 I'm talking about is our sputum microscopy, sputum smear study or sputum microscopy. So under the sputum microscopy, we can talk about acid fast bacilli staining, or we can also have this new thing called as auramin rhodamin stain. Okay, we will talk about it more as we go along. Now, the second alternative that we can use for the diagnosis is, one was microscopy, the second one is molecular methods. Right? So what are the molecular methods we have? Molecular methods that we have include, one is conventionally the line probe assays, and second one is CBNAT, what we all recognize as our gene expert, right? Gene expert RIF. So the line probe assays and CBNAT both are actually the DNA amplification methods. One is using a probe for the amplification identification, the other one is using a cartridge, right? Other one is using a cartridge for the identification of amplified DNA. Okay, these are molecular methods. Now, what are the methods that we still have in our list? We have culture as an important list. Now, culture is generally considered as the gold standard, right? Like even as low as 100 bacilli may be sufficient to give you a positive culture. The problem with culture is only the time that it takes before the result is available with us, right? Because tubercle bacilli are slow growing, slowly replicating bacilli. It is really difficult to achieve a growth in a shorter period of time. What are the culture methods we know? Right? There are two types of culture media, broadly speaking. We have this solid culture media. A classical example for that is LJ media, and we have this liquid culture media. Okay, so we will talk more about again these medias as we go along. Right now, just be aware that culture is considered as the gold standard. It can detect bacilli as low as 100. For gene expert, generally it takes around 130 bacilli for the identification of the tubercle bacilli in the specimen. 100 is enough for culture positivity, but the time that it takes, it is usually in terms of weeks, not in days. That's the real problem with culture. So we have solid media and liquid media. Solid media we have kind of given up because the turnaround time was very high. To give you a negative report, it used to take up to 84 days in case of LJ media. If you get a positive growth, yes, you might have a result much more before that in your hand, but to declare it as negative, it might take up to 84 days. That was one of the serious drawback of this solid culture media. So today mostly we use liquid culture media, and when we are using liquid culture media, again we are not trying to use those archaic older liquid culture media. So what we today follow is automated liquid culture media. Automated liquid culture media, right? So the classical examples of this is what we call as BACTEC. I'm not talking about just the BACTEC method. We are talking about BACTEC MGIT 460. So what is this? MGIT stands for Mycobacterial Growth Identification Tube. So automated identification mechanisms are there, right? That is what is currently mostly recommended. So currently, whether it is WHO or NTCP or most of the CDC and most of the guidelines, when they talk about culture, they recommend liquid culture media, and they preferably recommend automated liquid culture media like BACTEC MGIT, right? Okay, so this is the gold standard, as I've already told you. Now, what else we have in our armamentarium? The next thing we have is our immunological and serological test. Immunological and serological tests. So what are the immunological tests that are used? Okay, first thing, if you already noticed that I've been telling the role of antibody or humoral mediated immunity against tuberculosis is meager or almost non-existent. So there were tests, yeah, long back, I think 2010 or before that, there were tests which used to identify certain antibodies against tubercle bacillar antigens, which are now believed to be extremely insensitive, extremely non-specific, and none of the guidelines today recommend, and they are not available as such, right? So we don't need to even think that such tests were available in the past. The last such tests were available is 2011, and WHO has banned them since then, right? Okay, so then in that case, what are the immunological tests I'm talking about? Mainly I'm talking about two immunological tests, right? So those two immunological tests I'm talking about are, one is our tuberculin skin sensitivity test, TST, or what we all in India recognize as MAN2 test. And the other one is interferon gamma release assay. These are the two immunological tests we will be talking about today, right? So this is just a brief overview about the tests that are available with us for the diagnosis of tuberculosis infection. Now, as I've already told you, right, the most important MCQ that you might face is, what is the ideal specimen for diagnosis of a particular organ tuberculosis? For example, if we talk about pulmonary tuberculosis, right? So what is the ideal specimen? You can definitely consider sputum. Sputum is one of the specimen, and you can also consider bronchoalveolar lavage, particularly when the patient is not able to produce sputum. Now, as I've already told you during the discussion of clinical features, eventually most of the patients of pulmonary tuberculosis will become expectorative, right? So they will start coughing out the sputum, and you can definitely consider the diagnosis in that case. But if they are non-productive, you can do BAL, and sometimes, especially in the pediatric age group, because they have a tendency to swallow the sputum, you might have to even take up the early morning gastric aspirate as the specimen, right? So gastric aspirate can also be a specimen, particularly in patients with pediatric age, right? Okay, now when we talk about sputum, general recommendation is that we need 2 samples currently, and these two samples should ideally be early morning samples. But to make it convenient, most of the guidelines recommend that one sample should be a spot sample, and another sample, the second sample, is a early morning sample. But if you sense that patient may not return back with an early morning sample, if the compliance is a concern, right, in that case you can do consider 2 samples. Both are spot samples taken 1 hour apart. It can be an alternate approach, right? So that is about the specimen for diagnosis of pulmonary tuberculosis. Now, what is the ideal specimen for diagnosis of lymph node tuberculosis? So the starting point, as we have already discussed, is FNAC. You can consider open biopsy if FNAC is non-diagnostic, or FNAC turns out to be negative and you strongly consider it to be pulmonary considered to be lymph node tuberculosis. In that case, yes, you can go with the open biopsy. Otherwise, FNAC is diagnostic in more than 88% of the cases. What is the test to be done on that FNAC sample? That is, like, the starting test is usually or CBNAT or gene expert. Gene expert only is considered as the initial test. Okay, we will talk more about these tests later. Right now, just be aware. For pulmonary tuberculosis, sputum, BAL or gastric aspirate. For lymph node, it is FNAC that is considered as the ideal sample. Now, what is the ideal sample for pleural tuberculosis? For pleural TB, the ideal sample for pleural TB, we are talking about microbiological diagnosis now, not the clinical diagnosis. So pleural fluid is a very, I would almost say that it's a useless test for diagnosis of the tuberculosis microbiologically. Whether you want to culture, whether you want to do gene expert, it is insensitive. So gene expert is not recommended on the pleural fluid. So what can we do? Pleural biopsy is the ideal sample. Pleural biopsy is the ideal sample, and again, on the pleural biopsy, most of the guidelines recommend that you should go with gene expert rather than culture. If gene expert is negative, yes, you can think of culture. Okay, clear? So pleural biopsy is the ideal specimen whenever you're thinking of pleural tuberculosis. Now, if you're thinking of CNS tuberculosis, mainly meningitis, what is the ideal specimen? Yeah, right. So CSF is going to be our ideal specimen. CSF is the ideal specimen whenever you're thinking of the CNS meningitis, or the tubercular meningitis or CNS tuberculoma. Okay, now what is the ideal specimen when you are thinking of spinal tuberculosis? Okay, most cases of spinal tuberculosis are diagnosed based on radiological evidence and clinical context. But if there is a cold abscess, you can definitely go in for the aspiration, right? Aspiration, and again, aspirate is ideally subjected to gene expert. Clear? Okay, so depending on the organ affected, we have to choose the right specimen for the diagnosis of tuberculosis. Once you got the specimen, right, if it is sputum, we have the sputum microscopy. So under the microscopy, we have discussed 2 things, right? One, we discussed about conventional AFB using Zn stain, and we also discussed about this Oramin rhodamin stain. Now, between these 2, which one is more sensitive? Oramin rhodamin stain. Between these 2, which one is more sensitive? It is the Oramin rhodamin stain which is more sensitive. It is 20% more sensitive than our conventional AFB. So none of the current guidelines focus on Zeal-Nielsen stain and the conventional AFB. All the current guidelines recommend preference to Oramin rhodamin stain. So definitely be aware that, because it is 20% more sensitive. So 20% of those patients who could have been declared negative by Zn stain can be identified by Oramin rhodamin stain, right? So that is about the sputum microscopy. Now, the disadvantage of the sputum microscopy as such, when you use the conventional Zn stain or Oramin rhodamin stain, both also have limited sensitivity. So your Zn stain has sensitivity less than 50%. Your Oramin rhodamin may reach up to 70%. So sensitivity is extremely limited. Even in an endemic country, it has an extremely limited sensitivity. That's a serious drawback. Okay, so this is an image where you can see the Zn stain and you can see these acid fast bacilli here, and this image actually shows your auramine rhodamine stain, and you can see these fluorescent stained mycobacteria bacilli, right? Okay, so this is about a sputum microscopy. Now talking about the next thing, that is molecular method. So when we talk about molecular methods, the first thing that comes to mind is line probe assay. As I've already told you, it is probe based identification of amplified mycobacterial DNA. The advantages of line probe assay are: one, quicker downtime. Definitely not as quick as CBNAT or your gene expert, but still in comparison to your cultures, that definitely has a quicker downtime. So the downtime here is, or turnaround time here is, usually 24 to maximum 72 hours. Most laboratories will be able to give you a result within 24 hours time, like roughly one day it will take for you to get a line probe assay result, right? The second advantage of this is it can help you to identify MTB complex speciation. So when you see this Zeal-Nielsen stain or auramine rhodamine, you will only be able to identify acid fast bacilli if you're using Zn stain, or if you're able to identify mycobacteria based on this auramine rhodamine, but you're not able to speciate. It could be the MTB complex or NTM. You will not be able to speciate based on the smear, right? So here you will be able to speciate, not only identify it as MTB complex, you will be able to see whether it is your Mycobacterium tuberculosis or M. bovis or M. capreae, M. africanum. Within this MTB complex, you will be able to speciate. So speciation is one advantage. Okay. Then the third and equally, or in fact more important advantage is, apart from speciation, you will be able to identify drug resistance. These drug resistance is identified based on presence of certain DNA mutations. So what are the DNA mutations? For example, if we talk about rifampicin, the gene responsible for rifampicin resistance is RPOB gene mutation. RPOB gene mutation confers rifampicin resistance, right? Now this is for rifampicin. Now if you talk about INH, it tried to identify two genes. One is CATG. We did discuss about this, the catalase peroxidase enzymes that are defending the mycobacteria against the host cell's oxidative stress, right? So the same gene, as I have already told you, is involved in activation of INH. So if this gene gets mutated, INH resistance can be seen, right? So CATG is one. There is also one more gene called as INHA gene. So these two gene mutations can be identified in the line probe assays. So these are all first line agents. So these line probe assays can identify resistance to first line agents as well as second line agents. So the second line agents, like it can identify resistance to fluoroquinolones, it can identify resistance to certain injectable second line agents, second line injectable drugs. Resistance to SLIDs can also be identified by the line probe assay. So this is one particularly very important advantage. Okay, so this is about line probe assay. Now what are the disadvantages of line probe assay? The most important disadvantage of line probe assay is its poor sensitivity in patients who are smear negative. Poor sensitivity in patients with smear negative tuberculosis or sputum negative TB. In patients who are sputum negative, it has a low sensitivity, so it adds less to the diagnosis of tuberculosis. So its real utility in today's context is in identification of drug resistance rather than diagnosis, right? That's why when we talk about guidelines typically recommend CBNAT as your starting point. Those smear microscopy and all is like the thing of the past, no longer recommended. So mostly we recommend CBNAT as the starting point, right? After that we talk about cultures and stuff like that. Why we don't talk too much about the line probe assays in the protocols? It's mainly because it is not a great diagnostic tool as of now. Yes, it is good tool, definitely much better in comparison to your sputum microscopy and all. But in comparison to CBNAT, particularly in smear negative patients, it lacks the sensitivity, right? Okay. Now the next thing we have in our armamentarium is cartridge-based nucleic acid amplification test, and the most commonly used CBNAT is our Gene Expert, often written as Gene Expert RIF, right? Now what are the advantages of Gene Expert? The advantages is probably the shortest turnaround time, right? So the turnaround time or the downtime is less than 2 hours. Turnaround time is usually less than 2 hours. So that makes it a highly useful tool to make quick decisions when it comes to patient management, right? The second advantage of this is it can detect resistance to rifampicin, right? Rifampicin resistance is something that we are really bothered about, and it can identify the resistance to rifampicin based on the mutation in RPOB gene. So it can identify resistance to rifampicin, but it is like the disadvantage is it cannot identify resistance to INH, ethambutol. Even ethambutol resistance can be identified by line probe assay, but that cannot be identified by our Sibinet or GeneXpert. It can only identify resistance to rifampicin, right? That is one serious disadvantage. Okay, so its sensitivity is definitely superior to your sputum microscopy. So it can detect up to 70% of patients who have tuberculosis and they are smear negative. So up to 70% of smear negative patients can be detected as positive by GeneXpert. So it has a significantly better sensitivity in comparison to line probe assay or your sputum microscopy. Okay, so that is clear. That's why we are using it as a diagnostic tool. Added advantage is that it can also detect rifampicin resistance, but the disadvantage, it cannot detect the other drug resistance. Another serious and important disadvantage is with respect to this is it cannot speciate. It cannot identify species within MTB complex. MTB complex. So it will not be able to tell you that you have been infected with Mycobacterium tuberculosis, or whether you have been infected with Africanum, or whether you have been infected with Bovis. It is very insensitive in doing that. So speciation is not possible within MTB complexes. It identifies MTB complex and sets it apart from NTM, but it is not able to speciate within MTB. Now these line probe assays, as I've already told you, they can speciate, so they can identify the species. They can set apart your non-tubercular mycobacteria, and also within MTB they can identify what species is particularly responsible for the infection. So that's a real advantage of line probe assay, right? Okay, now another important disadvantage of Sibinet is in most of the tubercular effusions, say pericardial effusion or say pleural effusions, the amount of tubercle bacilli present is significantly less. So this effusion is more of an exudative reactive response to interferon gamma and other secretory cytokines. So the bacterial load is less and Sibinet falls flat at that. So Sibinet is not recommended for diagnosis of pleural tuberculosis in pleural fluid or pericardial fluid. Right? For that matter, even in ascitic fluid, it is not very sensitive. So what is ideal specimen when we talk about pleural tuberculosis? As we have already discussed, it is pleural biopsy. Yes, you can definitely do the GeneXpert on the pleural biopsy. It is highly sensitive in identification of the bacilli on the pleural biopsy specimen, not in the pleural fluid. Clear? Okay. Now, the next thing we are talking about is culture. So what are the culture media we have discussed? We have discussed culture media which can be called as solid media and which can be called as liquid media, right? So solid media, we have discussed two things. One is our LJ medium, which is a egg-based media, right? It's an egg-based medium. And then we had discussed this Middlebrook 7H10 and 11. These are agar-based media, right? As I've already told you, we have given up on it and we no longer use this solid media, right? So there's no point in discussing more about it. Just for the sake of exam, be aware that the turnaround time is usually 6 to 8 weeks before you will start seeing a positive growth, and to report it as a negative, it might take up to 84 days. So seriously long time. And once you've identified a growth, if at all you need to do a drug sensitivity testing, it's going to take further few more weeks. So it is like practically non-usable, right? So we mainly focus on liquid culture media or LCM. Now among the liquid culture media, preferred one is automated, fully automated, not manual, not semi-automated. So Bactec was the first semi-automated culture media, liquid culture media that came into picture. The same team has come out with a fully automated liquid culture media, what we call as Bactec MGIT 460, right? So this is considered as the current gold standard for culture. This is the current gold standard, right? Okay, now this will take around 2 to 3 weeks for a positive result. Means it might take 2 to 3 weeks for the identification of the growth. Okay, once you've identified the growth, because this media is not using any genetic probes to identify the resistance genes, right? The drug sensitivity testing will take further 2 to 3 weeks. Once you have identified the growth, you know that there is a tubercle bacilli, you have to do the drug sensitivity testing again, right? Okay, now to report it as negative, as I've already told you, it might take up to 6 to 8 weeks for a negative declaration on the Bactec MGIT system. Okay, other than this, yes, there are various other liquid automated culture media, right? So like there is something called as BACT alert, that is one more liquid automated culture media, not routinely used. So if you remember the Bactec MGIT, that's kind of enough, right? WHO also backs it up, and Indian authorities also back it up. Okay, so that is about the culture media. Now coming to the next set of investigations we were talking about, our immunological tests, right? As I have already told you, no longer we should be using any of the antibody detection methods, right? Absolutely not useful. So what are the immunological tests we know? One is our interferon gamma release assay, and the other one is tuberculin sensitivity test. Most commonly in India, we follow this MAN2 test, right? MAN2 test. Now, if you remember from the pathophysiology discussion, all these methods like IGRA as well as your TST are primarily trying to identify previous exposure to tubercle bacilli. Right? Both of these are mainly used for diagnosis of latent tuberculosis infection, and they're trying to identify previous exposure to tubercle bacilli by identifying the interferon gamma release in response to exposure to tubercular antigen, right? So what is the tubercular antigen that we use in TST? We use purified protein derivative. The amount of the purified protein derivative we use is 0.1 ml, which roughly contains 1 TU of the purified protein derivative. That this PPD usually contains around 200 of tubercle bacilli antigens, different antigens, and it is not species specific. Means it also includes your NTM and some of these M. bovis, MTB complex as well as NTM bacillar antigens may be present in this cocktail, right? So that is why this TST cannot differentiate between your NTM infection. TST can come positive in case of MTB infection or MTB complex infection. It can also be positive in case of NTM infection. It can also be positive following BCG. BCG, what we use is M. bovis, right? So BCG can also be, in case of BCG also, the tuberculin skin test may be positive, right? Now what is the protocol that we follow? Protocol is we inject this 0.1 ml of purified protein derivative intradermally, right? Intradermal route of administration, and 48 to 72 hours later we assess for the evidence of interferon gamma release clinically. Now what happens if the patient was previously exposed to tubercle bacilli, right? Now if you remember the pathology discussion, we were talking about primary tuberculosis, ineffective infection, and we spoke about the secondary reactivation. So every time a patient has got a primary tuberculosis, whether it is active now, reactivated, or dormant latent tuberculosis infection, or just had a primary tuberculosis from which is completely recovered and there is a healed lesion left behind, in all these cases the tuberculin skin test is going to be positive, because there was granuloma formation, there was Th1 cells being recruited, so there are memory Th1 cells present. Whenever you re-challenge this patient with the tubercular antigens, right, there will definitely be a reaction where there is interferon gamma produced. And as we have already discussed, interferon gamma is a vasoactive substance, so it can cause vasodilatation. So we are trying to identify this vasodilatation and inflammatory response after we injected the patient with the tubercular antigen, that is PPD in this case, right? So the assessment will be mainly looking for induration. So there will be induration and erythema. Erythema is not what we are taking into measurement. We are only looking at the induration, right? So this induration, if it is more than 10 millimeter, it is highly suggestive. We can say the TST is positive, highly suggestive of exposure to tuberculosis. In an endemic country, it is suggestive of exposure to tuberculosis. You would have got probably primary tuberculosis, or you might be having a latent tuberculosis, or you may be having active tuberculosis. It is very insensitive at distinguishing between these things, right? And if it is less than 5 millimeter, it is definitely negative, and that kind of you can say that there was no exposure to tubercle bacilli in the patient, right? And when it is between 5 to 10, it is considered as unequivocal, difficult to interpret, right? Okay. Now talking about the other immunological test, that is our interferon gamma release assay. So this is also a test which is trying to identify the interferon gamma release upon exposure to tubercular antigen if the patient was already exposed to tubercle bacilli. But here the tubercular antigen we are using is relatively specific to tuberculosis, MTB or MTB complex, I can say, right? Because if you remember again, when we were discussing the pathophysiology, we were talking about this one locus, virulence factor locus called RD1, which is concerned with secretion of ESAT6 and our CFP10 and our secretory system ESX1, right? So we are trying to basically expose the patient to these two antigens, ESAT6 and CFP10. Now, this interferon gamma release assay is relatively much more specific in comparison to your skin test. Why is it specific? It is specific mainly because the antigens we use, the RD1 locus, which codes for this antigen, is not expressed in majority of the non-tubercular mycobacteria. Few of them, and it is mostly expressed in the MTB complex, mainly again in case of MTB. So because of that, this is going to be relatively more specific, right? Okay, so it is usually positive in case of MTB. It is negative in case of non-tubercular mycobacteria. Most of them, yeah, some of them can cross react and some of them can be positive, but roughly speaking, it is usually negative in case of NTM, and it is certainly negative in case of BCG. Why is it negative in case of previous BCG vaccination? Because we used M. bovis, and I think I did discuss about this, that M. bovis strain is not expressing this RD1 locus, that the one that is used for vaccination, the strain that is used, the BCG strain that is used, it is not expressing the RD1 locus, so it will not be producing these two antigens. ESAT6 and CFP10 are not produced by BCG. That is why this is not going to be positive in case of previously BCG vaccinated individuals. Clear? So before we move on, just a quick recap. We mainly use this for diagnosis of latent tuberculosis, right? Latent tuberculosis. Now, this MAN2 test has been studied and validated in countries where there is high endemicity. So in India, if you talk about India, right, we should be preferring using the MAN2 test for identification of latent tuberculosis infection in comparison to IGRA. So IGRA has been validated in low endemic zones or low endemic nations. So in like Western world, they can follow IGRA, but for India, MAN2 is the preferred test for diagnosis of latent tuberculosis infection. Similarly, also keep in mind when we talk about children under 5 years of age, because it has not been studied and validated, IGRA is not the preferred test. So if you have to diagnose latent tuberculosis infection in children under 5 years of age, again it is the MAN2 test. Clear? Okay, so this is about the diagnosis of tuberculosis. Clear?